Next here. Our next paper is going to be Staged Repair of Laparoscopic Gastric Band Slippage by Dr. Eid.
Good afternoon. I'm presenting the staged repair of laparoscopic gastric band slippage. I am from Hackensack University Medical Center in Hackensack, New Jersey. No disclosures. So we've gone through this a couple of times today, but a quick introduction. Laparoscopic adjustable gastric banding has been shown, as you all know, as a good treatment for morbid obesity with significant long-term weight loss and low acceptable morbidity. However, there is reports that there is a high reoperation rate in comparison with the other bariatric procedures. Two of the most common complications which require reoperation after laparoscopic adjustable gastric band include band slippage and pouch dilatation. Some of the earlier data showed that when they converted to the pars flaccida technique, band slippage was reported at about 4 to 6%. Some newer studies report lower and higher. There is some conflicting data. So some of the treatment options when you do have a slippage is either removal of the band, revising it at that time, or converting to an alternative bariatric procedure such as a sleeve gastrectomy, as you saw earlier today, or a laparoscopic gastric bypass. So we propose a fourth alternative, which is a two-stage procedure. First stage is simply unbuckling the band, reducing the slippage, which is causing the symptoms, and then definitive revision at a later date. We prefer to perform this revision at about 6 weeks. This salvages the band, allows for the inflammatory process to subside prior to definitive repair. We assess whether it is a feasible alternative for treating laparoscopic adjustable gastric band slippage. We reviewed charts of 1,548 patients who underwent banding at our institution over a 4.5-year period. We identified 12 patients who underwent this staged repair of their gastric band. Data were all collected retrospectively, included age, gender, BMI at various time points, also the operative time and length of stay for the two operations, and more recently, we have looked at the weight of the patients at 3, 6, and 12 months following the final revision. So initially, the patient's gastric slippage is suspected clinically according to the patient's history. First step, we always remove the fluid from the band, see if the patient's symptoms improve. If the patient's symptoms do not improve, we proceed to a barium esophagram to make the diagnosis. So all these patients received a barium esophagram documenting their slippage. Like we said before, the primary procedure was all done with the pars flaccida technique. Our first stage of unbuckling the band, the mean operative time was about 25 minutes, and the patient stayed overnight. On average, they went home the next day. And for the second stage, most of the patients went home the same day. The average time for those operations was about 60 minutes. So all the patients' dysphagia and food intolerance resolved after the unbuckling. 11 patients had their bands revised, and 1 patient was lost to follow-up due to a medical illness. There were no immediate post-operative morbidities or mortalities. A little bit of a busy slide, but it shows the BMI initially, the BMI at the time of slippage. So most of these patients were successful with banding. The average time slippage was about 28 months. And the time between their first stage of the procedure and their final revision was a little bit higher than we would have liked, at 15 weeks on average. And their BMI at the time of revision, they gained 22% increase in BMI from the first stage to the second stage of the procedure. 2 of the patients had their bands explanted after the final revision. Both at the patient's request, they had complaints of persistent feelings of nausea and discomfort. However, esophagram and intraoperative evaluation of those patients did not demonstrate that the bands were in an appropriate position. Our follow-up at 3, 6, and 12 months showed no significant weight loss after the final revision, which is a contradiction to some of the literature, which shows that revision of gastric bands does lead to further weight loss. However, they did maintain the weight and ceased gaining weight at that time. So our conclusion, our preferred treatment of gastric band slippage in patients who have done well is still to primary reposition and revise the band in one operation. However, we believe that this 2-stage operation has its uses in cases where there's extreme inflammation and edema, which distorts the anatomy. It may be beneficial to treat the acute problem, allow the patients to get better. Also for non-bariatric surgeons, especially rural hospitals, we see a lot of patients there are a lot of patients with bands now. This may be the preferred treatment for them, and then refer the patient to a bariatric surgeon for a revision at a later date. The need for the reoperation and the weight gain was undesirable, we found in this study. But we still believe it is a viable option in the armamentarium of a bariatric surgeon, not necessarily the first line of treatment. Thank you.
I'll ask you, I saw that the time to slippage on average was around 20, 30 months.
Yeah, 20 months.
This follow-up was 12 months. So I think the greatest utility of this study will be in 2 years from now when we can see whether the re-slip rates have been affected or
Exactly.
not. I have a personal question here. I have a patient who I'm waiting to do a revision on that I can't get insurance to approve for that. Sorry. How would you get insurance to approve 2 cases?
So that is a good question, actually, and I'm not really involved with I am the fellow,
like to
so
know
I'm not really involved with the insurance part of it. But we are usually able to get them back, but I think that may be part of why the time in between the first and second stage is long as trying to get the insurances to approve it.
Bipan Chan, Cleveland, Ohio. I have a question for you. As far as the 11 patients, the type of slips that they had, you demonstrated one of the images there that looked like it was a pretty large anterior slip. Were all of them the same, or did you have some patients that had the concentric type of a dilation or the posterior slips? Or did you see any differences in those when you took them in the operating room? And I would agree with Dr. Sherman as far as the 2-year follow-up, how many of those patients do you think are going to have a recurrence? And then my last question is, as far as the mechanism, why do you think these patients they slip in to begin with? A lot of us that see these patients, most of the slip patients have very good weight loss, and most of them really love their band, and they want to have the band back in place. The majority of us try to retunnel that band, sometimes higher up in the stomach, so maybe you can try to address what you think the etiology of these are. So there's
Sure.
3 questions there.
Sure. So for repositioning the band, we felt that our retrogastric tunnel was pretty high, and that if we were to position it any higher, we'd be around the GE junction. That's why we didn't reposition it. That was our reasoning for that. What's your first question again? I'm sorry.
Types of slips, were these all anterior slips?
So all the patients in this study obviously were selected out. They all had pretty severe slips. Otherwise, we would have revised them. For the most part, they were anterior slippages, but I do remember a case where it was a concentric pouch dilatation, but I did not see any posterior slippage.
And then the etiology. So, you know, what are you doing this second time around?
That's different. I think allowing the slippage to be reduced, allowing the inflammation and edema to improve. I think there is a little bit of scarring there that holds the stomach in a certain position, and it's you know, when you rebuckle the band, we have revised the wrap occasionally in those situations if we needed to, but I think it just sits a little bit differently. The physiology has changed at that point, but I'm not sure why.
Thank you very much.
All right, thanks.